So our next speaker is Carolyn Selvage. Carolyn is a metabolic nurse educator, and a lot of us actually know Carolyn because we see her twice a year, usually about twice a year, right? At the adult metabolic clinic. So she does a lot of work on our behalf that we don't even know about. It's behind the scenes. For example, when you come in and you fill out your assessments, we do the questionnaire stuff, she processes all of that later on. So she does a lot of this work for us. It's all yours.
Thank you so much to Brad and Victoria for asking me to come speak today. I'm very excited to be here, see lots of familiar faces. So as Brad mentioned, I'm the nurse, one of the nurses at the Adult Metabolic Diseases Clinic. I work with Dr. Meze and Dr. Lehman. And my talk today is about clinical trials. I'm going to expand on what Dr. Selvanova talked about. I'll talk about what exactly are clinical trials, why they matter, what to expect with them, and how to find them. Okay. So we'll first of all talk about clinical trials, and then move into the registries. A lot of, at least I know, our patients are involved in the registries. And then at the end, talk about where to find these clinical trials, which I know was a question earlier. So let's start with the clinical trials. So there's a couple of different types of clinical trials. There's the non-interventional, which is just sort of a watch and learn. This is kind of the category where the registries fall under. And then there's the interventional, the test and control. This is where we develop the new therapies and drugs. Different phases of clinical trials, and then there's the blinded, often how they start, versus the open label. So let's dive in and see what these terms all mean. So let's talk about the interventional trials. So there's different phases. The first phase of the trial, which was talked about previously, it doesn't actually test how medication works. It's really just to see, it's the first, usually a small group, really focuses on the safety and the dosage before moving to the larger trials. The phase 2 is a larger group of people, looking at the dose, the strength, the medical intervention, focusing on safety, really fine-tuning it all. May test efficacy and often has a placebo group. We get a much better understanding of how this new drug is working. And then phase 3 is the largest group of patients, looking at the efficacy and safety. If results are good and data is used, it can determine approval. Often we see these double-blinded, randomized, placebo-controlled is preferred. And this is where we really get the highest level of evidence and treatment benefit. But the process can be quite lengthy, years in length, and it can be very cost intensive. Yeah. Efficacy is how well it works. Does this work? Does it not work? And I will talk about a recent trial too, to try and bring all these big words into play. So just to recap, phase 1 is this drug safe? Phase 2 is often, does this work? And phase 3 is, does it work better than an existing option out there? Okay, so what is double-blinded? Try and break down some of these big words that we hear with all these clinical trials. So double-blinded means that neither the participant or the experimenters know who is receiving which treatment. This helps to reduce bias, but it's not always feasible, especially with rare diseases. There's often really small groups of patients available for these studies. Open label, this is where often the studies move into, is when all parties are aware of which treatment they're being given. And it's often used when a placebo is not doable. And a placebo is like not the real drug. It's often a sugar pill or not a real drug. And so it's not doing anything. So often patients need to if we have a placebo control, you can really test if the group is receiving the drug versus a placebo, not the real drug, if it's actually working. And then there's often extension trials which go on for a fixed timeline from weeks to years. And following that period, patients both in the treatment group and the control group can often enter the treatment side of the study and continue to take it. So this allows for access to the treatment and extended commitment for the patient. So it can be quite a long, like I said, a long time period. So let's try and sort of bring all these words and look at one of the recent studies that Dr. Selvanova talked about and that was just recently published. And some people might have questions about one of the new therapies that might be on the horizon for us. So we recently had the PROPEL and the extension part of that, the OLE study that was recently published. So the PROPEL study is the one with the chaperone therapy. So it has an enzyme plus the miglustat. And in this study, they had about 122 people, so fairly decent size for a rare disease. And they had both patients that were on enzyme replacement and patients that were naive, which means they'd never received treatment. So one of the problems or difficulties, I should say, with going with studies with rare diseases is that patients have often already been on treatment. So it's really hard to get naive patients or patients that have never received treatment. So there were 122 people, and as Dr. Selvanova talked about, there was 2 endpoints there, that they looked at. And with studies, they need to have endpoints. What are we measuring? What's going to determine if this drug is working? So in this study, they looked at the 6-minute walk test and forced vital capacity, so your pulmonary function test. And they didn't find superiority. They were measuring it against myozyme. And superiority means that it's better than the current treatment. But I'll talk about that in a sec. They found that it was non-inferiority, which means it's not inferior, which are these big words, and you're like, what is the difference? So, but an interesting thing about this trial is that when they took out the naive patients and just looked at the patients who had been on enzyme, the myozyme in this case before, and switched over to the combination of the Pombiliti and the miglustat, they actually found that it was superior in both the 6-minute walk test and the forced vital capacity. And then they went on to another 2 years on the OLE study, so an extension study. So they're putting this study out further where these patients are going to get the Pombiliti and the miglustat. And so this is looking at the long-term safety. All the patients were able to switch over. So at the end, we had 4 years of data, which is a lot of years to look at this study. And they found that everyone sort of maintained. So they didn't get worse. There wasn't a big improvement, but they maintained, which is interesting. Currently, we're looking for this. These drugs are currently sort of looking, they've been approved, but we're looking for who's going to pay for them, which it always comes down to. Who's going to cover the cost of these drugs? But it's always exciting when there's something new on the horizon and to have choice for patients. So should you participate in a clinical trial? Some of the pros. You get closely monitored, lots of healthcare professionals, increased times being monitored by your healthcare professionals. You get to contribute to medical research, which can benefit future patients. You get access to novel treatments before anyone else. And you can connect with other patients in Pompe, with Pompe and their families. Some cons. There's uncertainty. Is this going to work? It might not. There's blinding. So you might not know which drug wing you're on. You might be on the group that has the placebo. You might be on the group that actually is receiving the treatment. You're randomized. During these studies, they still might be tinkering with the dose to find the effective dose. There is some side effects from experimental interventions that they're not aware of yet. Sometimes there can be invasive procedures. Sometimes they can look at muscle biopsies, LPs, depending on what they're looking for. Logistical concerns. Not every center does all of these trials, so sometimes you have to take the time and travel. And financial concerns, if you're traveling, if you're taking time off work, what is covered, what is not. So it can definitely be a bit burdensome. Okay, let's switch over and talk about the patient registries. So what exactly are these registries? So what they do is we take health information over a long period of time for people living with a specific condition. We can track long-term outcomes, identify trends and unmet needs, support future research and clinical trials, improve disease understanding and care pathways. There is a bunch of different registries out there, and not every center is involved with every registry. Because they are gathering data and putting it out there, you do need to go through IRB approval and get consents, and those take quite a bit of time on the clinical side of things. Probably the biggest one out there for Pompe is the Sanofi Pompe Registry. It started in 2004 and has 2,500 patients from more than 240 centers in 47 countries. Large amount of data in there, which is great. And it is the largest registry dedicated solely to Pompe disease. A newer one that's come out is the Amicus Pompe Registry. It's designed to better understand the long-term effectiveness, safety, and impact of Pompe disease, and to understand the natural history. It was started in 2023, and they're hoping to follow 500 patients from about 100 different sites for 10 years. Another one based out of the Netherlands is the IPA Pompe Survey. It's a joint international study and also designed to better understand Pompe disease and treatment experience. And then we also have the Canadian Neuromuscular Disease Registry. So it it's Canada-wide and looks at people diagnosed with neuromuscular diseases and aims to improve understanding of different neuromuscular diseases, one of which Pompe is in there. And they've recruited over 5,600 patients from across Canada since it launched in 2010. So this is all well and good. But how do we actually find these trials and registries if someone is interested in participating? Not every site takes on every single trial. It takes a lot to get a trial up and running at a site. So we would always recommend to take a look at the clinicaltrials.gov website if you never have before. That is often where all of the trials go. Last time I looked, a couple of weeks ago, there was about 29 different Pompe studies or registries on the go that are currently recruiting for. So take a look there. If there's anything that interests you, talk to your care provider, or most importantly, reach out to the study. They all have study coordinators. There's different inclusion, exclusion criteria for each of the studies. Often the studies will provide funding for you to travel there. But before you even would get to that point, they would require some information that your healthcare provider, I know for various patients have looked at studies around the world that we provide whatever is needed for the study site to get things up and running and to see if you actually can hit the inclusion criteria. Ask your doctor, ask if they know of any clinical trials across Canada. I know for Pompe, Dr. Tarnopolsky back east and Dr. Neil Kahn in the Magic Clinic in Calgary do a lot of studies. So you can find out if they have anyone that they're currently recruiting for. And as Brad mentioned, talk to the Canadian Pompe Association. They're often quite up to date on what's out there, or can point you in the right direction. And you can always reach out to myself at the adult clinic or at the children's clinic and see if there's anything sort of on the horizon. I don't think we currently have anything coming down the pipe. I know we did briefly look at doing the gene therapy trial, but that didn't end up happening for our site. At least not now. I think it's on hold for a little bit. But Dr. Lehman is always quite gung-ho on research, so hopefully there'll be some new ones on the horizon for us. Any questions?
So this is more just kind of asking your thoughts about something. One of the things that bothers me about registries is that for a patient to participate in a registry, sometimes the data is collected in clinic, sometimes it's collected outside the clinic.
Yeah.
So it's a task that the patient has to do.
Yes.
And the registries generally all ask the same questions.
Yes.
Like there's validated surveys that are in them and so on. So patients, if they want to participate in more than one registry, they're filling these out multiple times. And I mean, it takes time, right?
Yeah.
The data is very valuable. So the data is really worth collecting. But I can tell you as a patient, when I just filled out exactly the same information, it's kind of annoying, like it really is. Do you think that there's anything we can do? Like I know that there's rules, like we have to follow, but if there's any way that we can centralize the collection of that data so that it gets collected. For example, if you're collecting data for the Sanofi and the Amicus registry in clinic, can patients come in, fill a survey out once? It's not all the same information in both of them.
Right.
But at least the common information fill out once and get it used in both?
So we haven't gotten the Amicus registry up and going yet at our site, so I'm not exactly sure of the PROs, the patient-reported outcome, that they'll be collecting. But definitely, if there's overlap, I would not have you fill them out twice. I am the only person that puts the data into the registry. I spend about half an hour every day, every morning. I have a half an hour dedicated just to putting in information in the registry. And I feel like the information in the registry is only as good as you input. So we try and make sure from our end that we put very thorough information in there so that whoever's looking on the other end, whoever is trying to extract data from around the world, we've at least provided the best that we can. But I totally understand the burdensome of the PROs that we get you to fill out every time, but they are important. And I do look at them. I look at all this data. Yes, Michelle.
Thanks, that's great, Caroline. The tricky part of that is that you have to go through ethics, right, for any of these registries. So you're submitting what forms are going in. So each center has different ethics you have to go through. There's not like one universal place you submit for a trial for ethics in the country. It's each university is different. But I guess if the two different trials or registries were using the same whatever form, you're just saying you're using that and you can do it. It's just you couldn't extract. You still have to submit to ethics exactly what you're putting into each one.
And we do find across all the LSDs a lot of overlap in the PROs. The SF36 is a standard one that we see for Gaucher, Pompe, Fabre. But they are trying to evolve them a bit to be more specific, which is great to not to sort of look and trying to get the proper data out of each different disease.
And just to mention also, the CNDR is an easy one because that's a national one where you're just self-registering for Pompe. So patients just go on the Canadian Diseases Neuromuscular Registry. So it's more just a registry that goes through ethics. I think they went through Calgary. And to know where patients are with different neuromuscular conditions across the country, which then later can have benefit potentially for investigators who are part of that group to do research on, or more importantly, it shows a lot of the pharmaceutical companies where the patients are. So when they're looking at, should I do this trial in this country? Are there enough patients? So that's a separate registry that's a little less cumbersome. It's just sort of putting in your name and diagnosis.
Hi, we have a question in the chat. We have somebody asking, they have a 3-month-old baby diagnosed with IOPD, and they were wondering if you knew of any talks or any studies about clinical trials in Canada for gene therapy.
No, I'm just looking at Children's Hospital because we just do adults, and she's saying no. Dr. Salvanova is saying no. But look at the clinicaltrials.gov website. All of our patients across all of the metabolic spectrum, that's where we send them if they're interested, because there's hundreds of clinical trials around the world. And like I said, each site can't do every trial, but it's a wealth of information.
I think this okay, we're still on, cool.
Just about clinicaltrials.gov, even if your physician or Carolyn have suggested a trial to you and you've discussed it, go there anyways, because there's information there that they may not have let you know about, or it just went over your head, because there's so much to absorb. So go to clinicaltrials.gov. It's a really good place to go and at least get some information, and then you can carry it on further if you choose to.
And they have like I said, the contacts of the person coordinating those studies, so you can reach out to them and get tons of information. Great, thank you.